parvovirus B19. This is also known as Fisk's disease, or slapped cheek illness in older children, and that's due to the how the cheeks look. The infection can result in miscarriage, fetal anemia, hydrops, IUGR, or stillbirth. It can be contracted through a vertical transmission. There's no specific antiviral medication and no vaccine available. The infant would be monitored for hydrops using serial ultrasound. So what that means is you would do an ultrasound for baseline and then follow that every so many, I would say every so many weeks to see if the hydrops is worsening or not. The last virus on here is the enterovirus. This includes poliovirus, coxsackie-virus, and echovirus. The enterovirus is the third most common cause of viral outbreaks in the NICU, and this is following rotavirus and RSV. So what that means is you'll usually hear of these awful outbreaks in the NICU where a virus starts and it spreads. So they end up putting all babies in isolation. All parents end up wearing, contact isolation where they're wearing gloves and gowns. To anybody visiting the baby, they limit visitors until they can get the virus in the entire NICU under control. So this enterovirus would be the third most common viral outbreak in a NICU. It can be transmitted transplacentally or exposure to maternal blood or other secretions during birth. The onset of infection is usually 1 to 2 weeks after birth. Signs and symptoms include fever, irritability, lethargy, poor feeding, rash, respiratory, and GI symptoms. If a baby dies from this, the death is usually due to multi-organ involvement. And there's also no vaccine or any treatment approved for non-polio enteroviruses. So basically, these last couple of viruses are just supportive therapy. Here is a sample algorithm for secondary prevention of early onset group B strep, and we're going to talk about that in just a minute. So, here's some bacterial infections. So we've covered all the viral infection, and now we're going to talk about bacterial infections. So remember, if you were taking a test or HESI and trying to narrow down, first thing you want to think is it a virus that can be treated with antivirals, or is it bacterial and that you're going to treat with antibiotics? Antibiotics will not treat a virus. So first we're going to talk about group B strep. And you've got this note on here that says it's a leading cause of neonatal morbidity and mortality in the United States. It can group B strep is normal flora of the vaginal canal for women, so it doesn't affect us, but it can make a baby literally deathly ill. So what we do is give prophylactic antibiotics to laboring women, and this has significantly reduced the incidence and severity of early onset group B strep in the newborn. So you've noticed patients that are in labor, when you've been in labor and delivery for your clinicals, antibiotics is a priority, getting those administered on time. It takes about 4 hours for antibiotics to effectively cross the placenta and treat the baby. So if mom is group B strep positive, she's received antibiotics at least 4 hours prior to delivery, then that baby won't have to get a septic workup. So there's both early and late onset group B strep. So early onset group B strep occurs in the first 7 days of life, but usually manifests within the first 24 hours. So again, these babies are super, super sick. Risk factors include low birth weight, preterm birth, ruptured membranes more than 18 hours, maternal fever, a previous GBS infant. So if they've had a previous infant that got GBS sepsis, this baby is at high risk also. Maternal GBS bacteremia. So if the group B strep bacteria is in mom's urine, their babies are higher risk too. Internal fetal monitoring, maternal age less than 20, and if they are Hispanic or African American ethnicity. Results, so how it's transmitted is vertical transmission from the birth canal. It manifests as systemic infection or respiratory illness. Infants can rapidly develop shock, pneumonia, and meningitis, and the mortality rate is as high as 5 to 20%. Once you've seen a Group B strep septic baby, you will just never forget how sick they are and how terrible they look. Late onset Group B strep occurs between 1 week and 3 months of age, but usually occurs at about day 24 of age. It's also a result from vertical transmission or healthcare acquired infection or community exposure. So that's where hand washing and protecting infants is very important. Approximately 30% of infants that have late onset GBS develop meningitis, but the mortality rates are lower. Treatment is with antibiotics, including ampicillin and an aminoglycoside or penicillin G. And when women are in labor, penicillin G would be the antibiotic of choice to treat Group B strep. If she's allergic to penicillins, there are other drugs that are available. Next is E. coli, and it's responsible for 40% of early onset neonatal sepsis. Can cause omphalocytis, diarrheal illnesses, so they can get diarrhea, pneumonia, peritonitis, UTI, and meningitis. Risk factors include preterm birth, low birth rate, maternal infection, and prolonged ruptured membranes. It's often acquired from the maternal birth canal or the rectum during birth. Signs and symptoms are nonspecific and include fever, temperature instability, apnea, cyanosis, jaundice, lethargy, vomiting, abdominal distension, and diarrhea. And I think I left one out. Hepatomegaly. Treatment includes ampicillin or an extended spectrum cephalosporin and aminoglycoside for 7 to 10 days. Next is Staph aureus. And this is developed within the first few days after birth and involves the skin and soft tissue. Can infect the eyes, or they can have small vesicles or pustules on the baby's skin. So staph can cause eye infection, or if it's on the skin, they'll have small vesicles or pustules. It's also known as scalded skin syndrome in the more serious, where they have bullous lesions, so it greatly involves the skin. It's often colonized on the hands of medical and nursing personnel, so you just cannot wash your hands enough. And the treatment is a semi-synthetic penicillin, and because we have to worry about MRSA and those super bugs that are becoming resistant to antibiotics. Next is listeriosis, and this is a foodborne infection. It can be transmitted through the placenta or an ascending infection during birth. You want to suspect a listeriosis infection if the amniotic fluid is brown stained. It can cause miscarriage, preterm birth, and stillbirth. Early onset is more common than late onset. Signs and symptoms are sepsis-like symptoms, acute respiratory distress, and pneumonia. And treatment is with ampicillin and an aminoglycoside. And finally is chlamydia infection. And this is one of the most prevalent STIs in the United States. It's acquired in 25 to 60% of all vaginal births. Causes neonatal conjunctivitis and pneumonia. Can also cause early and late pregnancy loss, stillbirth, premature labor, and postpartum endometriosis. For an infection of the eyes or conjunctivitis, the baby will have redness of the eyes, edema of the eyelids, but note that it'll have minimal discharge. Develops within a few days to several weeks after birth, and can be treated with oral erythromycin or azithromycin. For pneumonia, it has a gradual onset between 4 and 11 weeks of age. It begins with a runny nose and progresses to tachypnea and coughing, and it's treated with oral azithromycin or erythromycin, so the same antibiotics. Erythromycin, just one thing to note, can cause infantile hypertrophic pyloric stenosis, and I don't know if you've had pyloric stenosis in your pediatric class, but what you'll see are the signs and symptoms include a feeding intolerance, projectile vomiting, and abdominal distension. So erythromycin, if a baby was prescribed erythromycin, this is one thing you would have to teach parents to watch. So again, here's one of the most, it's the most common STI in women in the United States. So in my notes, you'll see that the last couple notes here under chlamydia are italicized, and that's information I pulled from chapter 7 in the book to help you all prepare for HESI. It's treated, so the woman is treated with erythromycin or doxycycline to treat chlamydia, and if the patient has gonorrhea, it's treated with Rocephin. So just note those are kind of extra tidbits. Okay, the final neonatal infection we're going to talk about is a fungal infection or yeast infection. Common ways it shows up are thrush, diaper dermatitis. You treat with an antifungal ointment such as nystatin or mucostatin or monostat applied 3 times a day for 7 to 10 days. And just note, if the mother is breastfeeding, you want to treat her, because if you get, like, for instance, if you get thrush cleared up in the baby and mom has yeast on her breast, then you're getting the baby treated, but the source continues. So mom would want to be treated for yeast infection also.